There we go. We appreciate being able to see each other. So if you'd like to have your camera on, you are welcome to do so. And it does help the presenter, of course, but we also acknowledge that there may be reasons why you want to keep your camera turned off. If you would like to rename yourself or to include your pronouns, please do so. And if you need help with that, please let me know. You can chat with me privately. I would like to take this moment to read our land acknowledgement before we get started. Acknowledging that we reside on the homelands of Indigenous peoples is an important step toward recognizing the history and the original stewards of these lands. The intent of a land acknowledgement is to extend beyond spoken or written words. It must be implemented thoughtfully and meaningfully and be reinforced by direct support and consideration of Indigenous peoples. As we gather, we honor and acknowledge that the University of Colorado's 4 campuses are on the traditional territories and ancestral homelands of the Cheyenne, Arapaho, Ute, Apache, Comanche, Kiowa, Lakota, and Pueblo and Shoshone nations. Further, we acknowledge the 48 contemporary tribal nations historically tied to the lands that comprise what we now call Colorado. Acknowledging that we live in the homelands of Indigenous peoples recognizes the original stewards of these lands and their legacies. With this land acknowledgement, we celebrate the many contributions of Native peoples and also recognize the sophisticated and intricate knowledge systems Indigenous peoples have developed in relationships to their land. With that, I will turn things over to Monica, who will be introducing our speaker.
Hi, everyone. Jason, welcome to IBS Speaker Series. We're so excited to have you. I feel so lucky. I've known Jason for a couple decades now, Jason, right? Different efforts in different ways, collaborations, and as a part of the National Child Traumatic Stress Network. But we're thrilled to have you talk about statewide dissemination of evidence-based treatments and the lessons learned. And you are, it's exciting to have you. I know you're Vice President of Mental Health Initiatives at the Child Health and Development Institute, and you're also a licensed clinical psychologist, and you are serving in different positions, and people can read your background, but as assistant clinical professor at UConn Health, Child Studies Center, and Yale. But what I'm so impressed is that Jason is he's always steeped in the research, but he is so applied. So everything that he's doing is completely community-based, all the trauma-informed work and trying to bridge the gap around science and practice, and just has done a ton of presenting and publishing in these areas of evidence-based screening and assessment and implementation science. So I was hoping that we would have Jason come. A couple of years ago, we talked about coming in person, and then with COVID, but he graciously agreed to provide, this talk virtually. And we're just thrilled to have you here. And I just want to encourage everyone with Jason, ask any and every type of question, because he really can feel that, because he is so on the ground with practitioners, and then also, obviously bringing so steeped in science. So thanks, Jason, for coming. And I don't know if Fernando, you wanted to bring anything else. He also, I will say, I just got an amazing shout out to Jason, because his institute, you won an award, I guess, for one of the best places to work. Is that right? And so that was kind of cool to see that this morning. So anyway, without much ado, more time for you to share with us.
Well, thanks, Monica. That was very generous, and thank you, Cindy and Fernando, for the invitation to talk. I definitely can't answer any questions, so I'm going to send any I can't answer to you, Monica. But I'm gonna kind of walk through our experience in Connecticut disseminating evidence-based treatments over the past 15 years, and I want to say right off the bat that a lot of this work, most of this work, has been in outpatient community mental health settings. I know there's a range of settings where evidence-based treatments can be disseminated in home and in residential and other settings, but really most of our work has been in outpatient, with some in schools. So my perspective on this is really coming from that lens of outpatient generalist community mental health. All right, let's see. So I do want to say that I am from the Child Health and Development Institute. That's where I've been for the last 15 years. And we are a kind of a unique organization in that we're an independent nonprofit. We're quite small, we have 30 something employees. And our mission is really to improve the health and well-being of all children in Connecticut. And we do that through working as an intermediary with, the community mental health providers, the schools, as Monica mentioned. We work closely with academic partners and researchers, and we work with our state policymakers in state agencies, legislators, to think about how to bring all of those perspectives together with family advocates and consumers to make sustainable improvements in children's mental health. So what I was planning to talk about today is kind of our evolving approach to EBT dissemination, focusing on outpatient, some of our results and outcomes, but then, where I think we're going in the future. And this is where, for me, it's kind of exciting to think about what comes next. And so I'm going to tie in some recent research that's come out and what we're thinking about EBTs. And I think I felt like I couldn't do this presentation on EBTs without an unbroken bridge, because that's kind of a law of EBT research. But I think, it's important to keep in mind, oh, my slides are auto advancing. It's important to keep in mind that the goal for improving the research to practice gap is not just to put EBTs out there, it's to improve the quality of services that kids get. And EBT dissemination is one strategy to do that, but there are many others. There are many other ways of improving services. And we know that EBTs and other research in general takes a long time to filter down into the community, that EBTs really aren't that widely available. I'm sorry for my slides. And 15 years ago, this is kind of where we were with, we need to get more EBTs out there. The other example that I like to use is how to disseminate EBTs is quite complex. And again, thinking about our initial efforts, 10, 15 years ago, the example of hand washing. So in hospitals across the world, and in the United States specifically, a number of years ago, the CDC looked at how many deaths were being caused by hospital-acquired infection, 100,000 deaths annual in the U.S. alone, billions of dollars, because people were getting infections in the hospital. And what is the evidence-based treatment, or one of the best evidence-based treatments for that is wash hands and get rid of pathogens and germs. And so the World Health Organization put together this set of guidelines and disseminated it as an evidence, kind of like an evidence-based practice in the US and internationally. And they got the rate of compliance with effective hand washing from 50% up to about 67%. So good improvement, but still, still some room for growth. And, this is hand washing. It's a relatively simple evidence-based treatment. But does anybody know how many pages the World Health Organization guidelines were? Anybody have a guess? Well, I'll just tell you, it was 270 pages of how to wash your hands effectively in hospital settings. And if you think about the simple, hand washing is a relatively simple thing, but in order to disseminate it and to make it work well, you have to take into account a lot of different things: the type of sanitizers used, the cultural conditions of killing bacteria for Buddhists is in there. Where hand washing stations are placed in hospitals, how often they're done, what do you do when people's hands get chafed from washing too much? So all of that to say that for a very simple EBT, it's really complex. And then when you get into the complex EBTs, like psychotherapy, which is, incredibly complex, multiple sessions, range of clinical problems, ages, the therapeutic relationship, all of this goes into how do you disseminate an EBT, and that becomes more complex. So a few things about outpatient children's mental health I think are important to keep in mind. We know that there's lots of kids with mental illness. Most of them are not receiving any treatment. The recent study from David Finkelhorst showed more than half of kids who had clinically significant PTSD symptoms weren't receiving any treatment in the last year at home, in school, in the community, or anywhere. We also know there's disparities in access to treatment and outcomes. And when you look at outpatient treatment across the board, on average, only about half of kids who get outpatient treatment get better. And a small percent actually get worse, but only half get better. And then what does outpatient treatment consist of usually? It's very heterogeneous. There's few EBTs that are scaled up in outpatient settings. You might have a handful here and there, but it kind of looks like, I think, the Facebook marketplace of cars, where you got lots of different varieties. Some might be drivable, or some might be effective, but you got a lot of other things that you got to sift through. And in outpatient mental health, clinicians are generalists. So they, in Connecticut, our average caseload across a 20-something big mental health providers is around 50 to 60 or higher cases on a caseload. We have some agencies where it's 80 to 100 cases on their caseload. So what does typical treatment look like? It really runs the gamut from, people who are using CBT approaches thoughtfully to, non-directive talk therapy, or even playing Jenga or games in session and, calling that supportive therapy. The context of our EBT work, I think, is also important because, all states are a little bit different, but in Connecticut, our child mental health mandate falls under the Department of Children and Families, which is also responsible for child protective services. We don't have an integrated adult child mental health agency there, that comes with some pros and cons, but it does mean that DCF focuses on children's mental health. DCF funds a range of services across different levels of care, including outpatient services, and has for a long time, even before we started, this work 15 years ago, has started with EBTs in in-home settings. And one of the things that has driven a lot of the EBT work in Connecticut initially is that in 1989, the state was sued for not meeting the mental health needs of children in the state's care. And that the consent decree from that lawsuit actually still has not been resolved to this day. The state is still under court order, although I think it's very imminent. But now for 30-something years, the state has been trying to meet the benchmarks for mental health needs. And early on, that involved moving kids from congregate care settings to the community and funding a number of in-home EBTs like multisystemic therapy and FFT and ICAPS in Connecticut. And where I'm going to kind of talk most about is the outpatient EBT, starting with TFCBT. And, I show you the Facebook marketplace of cars. TFCBT is kind of like the Tesla of outpatient evidence-based treatments, in that it has a lot of good research showing its effectiveness for kids with trauma. And back in 2007, when the state wanted to bring evidence-based treatments to outpatient settings, this is what they selected, and they turned to us at CHDI to help disseminate it across the state. And the goals, of course, were to make it available to as many kids as possible and to get good outcomes. But I see there are some chat. I actually couldn't read the chat comments. So if you do have anything, well, it's just hard for me to multitask. If you have anything that you want me to clarify, raise your hand or shout out so I don't miss your comment in the chat.
Don't worry, you're all set, Jason. They weren't
Okay.
Just commenting on what you were saying.
Thanks. So I mentioned that CHDI is an intermediary organization, and I think this has been an important part of the state's approach to EBTs is that they've looked to us and to other another intermediary organization in the state to help disseminate evidence-based treatments. And I mentioned that we work with these different groups of people who are invested in children's mental health to really bring best research and practices to the community. So the way that we started, and actually it's how I met Monica back in, I think it was 2007, 2008, was the state funded learning collaboratives or breakthrough series collaboratives to disseminate TFCBT across the state using this intensive 12 to 18 month process where teams got together from a number of different outpatient mental health providers. And they learned over the 12 to 18 months at in-person trainings, through ongoing work between in-person trainings, collection of data. And data is one thing I'm going to talk quite a bit about. But this was really a very time-intensive, cost-intensive process to get EBTs out there. And over the past 15 years, I think we've run now probably 18 or 19 different learning collaboratives to disseminate EBTs. In terms of data, I think data has been one of the strengths of our learning collaboratives and EBT dissemination efforts. And we think about how to collect the least data possible. So we work with a lot of researchers and model developers who have, recommendations or sometimes requirements for what they need for their EBTs. But a lot of our work has been to simplify and streamline data collection from outpatient providers as much as possible, because it's challenging for them to do. So these are some of the considerations. We try to find, the briefest, cheapest, or free measures. These are some of the measures that we've used. Our state requires the Ohio scales of all contracted providers. So that's kind of our general behavioral health measure that's used across the board. And then for TFCBT, we use trauma-specific measures as well. I just want to give a few different examples of data, because I think the way that we think about data and use data is, is different than researchers or model developers sometimes think about it. So I mentioned we try to collect as little as possible, and we also try to report it back to providers as quickly as possible. So on the right side here is just a single client look at PTSD symptoms over time. And as part of this EBT work, we worked with the state to build what's called EBT Tracker. It's a data system that looks at evidence-based treatments and outcomes and fidelity, brief fidelity measures. And the graph on the right shows what a clinician might see if they're using measures over time. The graph on the left looks at statewide quality improvement indicators for how an organization or program is doing with their implementation. So that includes things like how many kids are being served, what percentage of kids are successfully engaged into treatment, what percent are actually getting regular care, meeting at least twice a month with a clinician, completing treatment, TFCBT in this case, successfully. And we also report on how many children have assessment data, completed assessment data. And these QI indicators are used in ongoing consultation with the providers to help them, improve their implementation. This is just another example. This one was schools to look at how many kids they're seeing over time, intakes, discharges. This was specific to CBITS and bounce back work. And this would be one specific school that's kind of in the early stages of implementation. And then at the statewide level, we aggregate the data and share it with our state, which is funding this work and is a partner in the work, to look at across the state, how many kids are getting treatment, what are the trends over time, and and to use that for kind of planning at the statewide level. Where do we need more? What do we need more of? And where to put additional resources. The map on the bottom is just another way that we report data sometimes to look at access. So where services are available, in this case, it's CBITS in school-based treatment, but we do this with other models as well. The dots show where services are available, and then the shaded areas show where children live who are accessing those services. So we can look for geographic gaps. So our initial TFCBT learning collaboratives, the first 3 years worth, where we trained 16 community mental health agencies. We published this in a paper and showed that, overall those agencies served 588 kids. We trained 179 clinicians. And I think most importantly, the children showed good treatment outcomes. So the table shows pre to post treatment outcomes in PTSD symptoms and depression symptoms for kids that got TFCBT. The flip side of this was that we knew that there are many more kids out there who are suffering from traumatic stress than are actually getting treatment in these communities. So, even if we get good outcomes, we're still missing a lot of kids. And we know that these mental health organizations are serving more kids with traumatic stress than are getting treatment too. The other thing that came out of this when our learning collaboratives ended was our providers all said to us, this has been great. We've learned how to do TFCBT, but if you just leave us and let us be, we're not sure we can sustain it. We need some help for training new clinicians. The data has been very helpful to the providers. So they wanted ongoing reports about their progress that they could use. And so we worked with the state to put together a small center to sustain TFCBT at these agencies by providing them with new clinician training, consultation, and some data collection and reporting. The other thing that we started to realize is that even though these services were available, there were not a lot of referrals for them from the child welfare system and the juvenile justice system, and others where we know that there are kids suffering from trauma that could benefit. So our next iteration of this TFCBT work was to do a learning collaborative jointly with the behavioral health providers and their local child welfare partners. And this was done through a federal grant from the Administration for Children and Families. And we ran some learning collaboratives, you can see from the circles, that had integrated teams of behavioral health and child welfare. And we also include family partners on all our learning collaborative teams. And the goal here was really to increase access to TFCBT for kids in the child welfare system. So while the behavioral health providers are trained to deliver TFCBT, the child welfare workers were trained to screen kids for trauma and refer those who seemed appropriate for TFCBT. This was done also over several years with several learning, different cohorts in the learning collaborative. And ultimately, we actually found that the child welfare workers could screen for trauma. They could refer kids for TFCBT, and they increased the numbers of each. And we also saw that the relationship between child welfare and behavioral health really improved quite a bit. At the beginning of these learning collaboratives, many of the people in the same geographic region from child welfare and behavioral health didn't talk to each other or had bad blood because they never call me back. They never call me back. And working together on this learning collaborative really helped those relationships. Again, they also said, how do we sustain this, once we don't have the support for screening and data reporting and training new child welfare workers or clinicians. So around that time, we had a life-changing event in Connecticut in the Newtown tragedy, which in addition to many other things, resulted in some legislation in the state around children's behavioral health. And this is a context for, for kind of, the next few years of work. But the gist of it is that the legislature tasked a group of people with creating a statewide children's behavioral health plan, which is publicly available on that website. And it included some funding for trauma-focused mental health services for kids, some additional funding. And so after that, that legislative session following Newtown, the state invested in additional evidence-based practices. They sustained TFCBT, invested in the match ADTC model, CBITS and bounce back in schools. And that was supplemented by some additional federal money for ARC and CFTSI and Target in outpatient settings. So our kind of model since then, when we've had multiple evidence-based treatments to support, has been this what we call the Dissemination Support Center, but it's really kind of a statewide coordinating center in EBTs. And the way that we think about it is for organizations that have not yet been trained or implemented in EBT, they often do still go through breakthrough series collaboratives. We do fewer of those now because most of our larger organizations already offer EBTs. But we require any organization that we train to kind of go through a selection process and to develop a contract with them to really formalize the agreement. And the agreement is that through state funds, we will, pay for their training, we'll pay for their consultation, the data collection and reporting, give them a lot, but in exchange, they have to commit to the staff time necessary to actually deliver the EBTs and to get good outcomes. So our role at CHDI includes the data system development and data analysis and reporting. We have a public EBT directory that anybody can look up and find where there are EBTs near them. We do implementation consultations, so working with each provider on a regular basis, at least quarterly, if not more frequently, to share their data on whatever EBTs they're implementing, and then work with them on QI plans to improve their performance. I'm not going to go through all of the rest of these. I think many of them are self-explanatory, but the one other one I do want to say is the sustainment funds are state money that we're able to allocate based on performance. So the organizations that do more TFCBT or match or get better outcomes or serve more children, they get the split of a pool of sustainability funding to help offset the additional time and cost it takes for them to do that. This is just the example of the public EBT directory that I mentioned, which is searchable by model. It just describes a little bit and then gives you contact information for whatever model or models that you want. And we share this with child welfare, with juvenile justice, with the public, schools, anybody that might make a referral for mental health services. So this is kind of where what we've looked like in terms of the number of kids who've gotten one of these EBTs. And these are not numbers of every EBT that every kid has gotten. They're just the numbers of those EBTs from the previous slide that CHDI is responsible for disseminating. And you could see up until the pandemic, there was a nice steady increase each year. The last 2 years of the pandemic has been, has been tough on everyone. Definitely been a decrease in EBT use. I think part of that has been a decrease in services, at least initially, but the other part has just been the workforce has been so stressed and strained that even if they have begun seeing more kids, they're slower to get back into delivering the EBTs. And then for me, probably the most important slide is are kids getting better? And this is just an example from TFCBT, but the data look pretty similar for the other EBTs. So based on where kids were prior to treatment and the orange or yellow bars and where they were at their last assessment, they're generally falling below that. That red line is the cutoff for likely PTSD diagnosis based on symptom severity. So based on both child and caregiver report, they're showing pretty significant improvement in their symptoms. One of the things that we did recently to kind of step back and look at the impact of EBTs on our system and our broader population of kids getting mental health services is that we recently became responsible for providing data analysis on the whole outpatient network. So there are about 25,000 kids who are served in the state outpatient network. Some of them are getting EBTs and some aren't. But as part of that work, we looked at the effectiveness of EBTs compared to usual care over the past several years in Connecticut. And what we found is that we found a few things. One is that the overall treatment effect, which is the graph here, for all kids, regardless of what treatment they got, is kind of modest. About half the kids showed partial or reliable improvement using a CGI. Using the RCI, the Reliable Change Index. But half the kids didn't get better or even got worse. So overall outpatient, pretty consistent with prior research. It works for about half kids and half the kids it doesn't. We also found that about 12% of those kids had gotten a specific EBT like TFCBT or MATCH or one of the other ones that we've been disseminating. About half of kids, based on clinician report, got CBT. And then we looked at the comparisons in outcomes for kids who got different types of treatment. And we found that the kids who got a specific EBT like TFCBT or MATCH got the best outcomes. Kids who got CBT were a little bit below that. And then kids who didn't get any EBT, usual care, were below that. The effect sizes there were also pretty modest. They were pretty modest, but they were there. And then the last thing that we found is that across all outpatient, there were significant disparities in outcomes for children of color. Latinx and Black children both got poorer outcomes overall compared to white children. But when we looked at the EBTs, the use of EBTs actually reduced those disparities. It didn't totally eliminate them, but it did reduce the disparities, particularly for Latinx children and to a lesser extent for Black children. One of the ways that CHDI works is, we are not an academic institution. And so I think this something we think about a lot is how do you communicate and who's your audience? And, I just shared this paper that we did publish in a journal, but we also did a lot of other things with it because, I know that some of the people we want to reach don't read journals. And particularly our state policymakers and our state agency partners, they do read some of the briefer things that we put out. So we've developed issue briefs, which are 2-page summaries of this research and other topics, and online infographics and things like that that really simplify the message of what we're trying to say, that are targeted to the right audience. All right, so kind of where we are now is Connecticut's has a Family First Prevention Service Act plan that was just very recently approved, and it's going to involve additional EBTs that we don't offer yet. So that's coming down the pike. And then there's been a big focus here on school mental health in our legislative session, which we're right in the middle of right now. There's an enormous amount of children's behavioral health legislation that's being proposed. I think is very likely to pass to improve services, particularly in schools, but in other settings as well. And so I want to say a couple of things about the future directions now. One of the things that our providers have spoken about from the beginning is the added cost of training in and delivering evidence-based treatments. And so, usual care, it mentions kind of the Facebook marketplace where you don't know what you get versus an EBT, and just, the amount of time it takes for an individual clinician and for an organization to train a team of clinicians and supervisors and intake staff and, and anybody else that needs to know about one specific EBT. And in response to our providers, we worked with them a few years ago to collect some cost data about, what does this actually look like in dollars. So no matter what they do, they get paid somewhere around $100 a session. Even if they do the EBT, there's no enhanced rate. And as far as I'm aware, there's very, very few places in the country where there is an enhanced rate in outpatient settings. But what our EBT providers reported to us is that to participate in a learning collaborative as a team, it cost them about $90,000, and this is 10 years ago, so their costs have gone up. And just to sustain TFCBT for a year with their team and their organization costs them about $65,000. So what many of the providers will tell us is, we can't see more kids. We can't serve more kids with TFCBT because we lose money, every time we do that. It just costs too much. So some of the recent research, I think, ties into where I think we're going and where I'd like to go. One is task shifting. So, our behavioral health workforce is really strained and stressed. It's going to take a long time to increase the pipeline of behavioral health workers, behavioral health clinicians. And so task shifting to lay health workers or peer workers is one way that we can add people to the workforce that can help augment what clinicians do. And they can do a number of things, from working with children or families with less serious problems to working to engage families into treatment. But there's some good evidence that they can be effective. Another one is, how much expert consultation and fidelity do we need? And, I think some of the recent research, and I put a couple of the papers on the screen here, suggests that more consultation is not necessarily associated with better child outcomes when it comes to evidence-based treatments. There was one recently on a measurement-based care intervention and one on PCIT recently that showed more consultation didn't result in better outcomes. And then similarly with fidelity, there's certainly a lot of good reasons why we want to make sure interventions are delivered with fidelity, but rigorous fidelity monitoring in community-based mental health, particularly in outpatient settings where clinicians have these high caseloads, is really, really difficult and expensive. And a recent paper showed that for PCIT, fidelity was not associated with child and family outcomes either. Now, I'm sure that there's lots of other research that shows that fidelity is important, but I think we need to do a better job of figuring out where that line is between fidelity and tailoring, and how much is needed. The third piece on here is brief interventions. So there's been a lot of work lately on single session interventions being effective for mental health concerns, and even brief 3, 4, 5 session interventions. These are less expensive to train on, less expensive to deliver. And if we can give families that have fewer or have less serious concerns a brief intervention and then let them go on their way, that opens up capacity for others. Another kind of innovation that I'm really interested and excited about is matching therapists to clients. So there was a study on the bottom here that looked at matching clinicians who had demonstrated expertise with specific problem areas like anxiety or depression or sleep problems, and then assigning them clients that matched their expertise. That actually resulted in better outcomes without any changes to the treatment interventions at all. And then finally is usual care changing. So 15 years ago, I think usual care really was the Facebook marketplace where you don't know what you're getting. But I think over time, these evidence-based treatments have permeated usual care in different ways. So, we have clinicians who may be doing TFCBT with a handful of clients, but I think they're also using some of those principles with their non-TFCBT clients or their usual care clients. And there's the paper I think I put on here from Mary that looked at Match, found that they actually measured usual care and found that in Australia, usual care was increasingly using evidence-based principles. And so there was no difference between usual care and Match in that study. So a couple things I think that we should really focus on in EBT dissemination is to shift from the small scale thinking to what is really scalable across the system. And, if you have an evidence-based treatment that's going to be very time and cost intensive to scale up and is not going to serve a large percentage of kids in an outpatient setting, to really rethink, is that the right intervention for that setting? So we need things we can scale up and deliver at less cost. Some of the things that we've learned from our learning collaboratives and other work is keep the data, but keep it very small, the least data possible. The contracts and the formal relationship, and avoiding just training and praying. So, opening up training to anybody that wants to get trained in EBT doesn't, I think still doesn't work very well. To pay for performance when you can. And, our providers really value that, relatively small pool of money that we give them based on their performance. And it helps them support the additional costs of the EBTs. And then I think transdiagnostic and interventions and interventions that have more broad applicability to the populations that we see in outpatient settings or in schools, interventions that can be used for any kids in those settings. And that, we're moving away from more intensive learning collaboratives or other, training and dissemination requirements that are very time consuming without, real clear evidence that they're worth the cost. And we're also going to move away from complex EBT models that don't have the money to sustain them or to train them. So really looking for not the Teslas anymore, but I don't know what it is, the Ford Taurus or, old reliable, but not the gold standard. And then we're really trying to add more brief evidence-based treatments, to use measurement-based care as an evidence-based treatment that can be used in any setting with any child, with any problem, and has good evidence of its effectiveness. And thinking about low touch support. So clinician assisted apps or books or websites, or even apps or books or websites that families can use and access on their own that have some evidence of effectiveness for mental health concerns. And I mentioned task shifting for peers and lay health workers. And then I think the thing that, I think we often continue to struggle with is fidelity versus tailoring. Where is the line between how much fidelity do we need and how much we can tailor to specific populations? This is an issue brief that we put out recently. Monica mentioned, I think, that looks at future directions and how to modernize outpatient behavioral health, including evidence-based treatments, but not just disseminating evidence-based treatments. Touches on many of the things that I mentioned. And then I think my last slide is that, I think when we're trying to improve services, we always add. We do more and we ask our providers to do more. More clinical consultation, more fidelity monitoring, collect one more measure, do one advanced training now that you've done the basic training. And that we really need to think about how we can subtract from what they have to do and still get good outcomes. And, this is a paper that I just thought was interesting in that it showed when people are faced with complex problems, they tend to add instead of subtract, even if subtracting gets you a better solution. All right. I know I ran a little bit over, so I'm going to turn it back to Monica or Fernando or take some questions. I'm not sure.
Thank you so much, Jason. Yeah, we'll take some questions. I don't know, Monica, if you want to moderate, that's perfectly fine. Of course, I'm just, I can help if otherwise people, if you'd like to, or Jason yourself. But yeah, please raise your hand or unmute yourself if you have questions.
And if nobody has any questions for me, you're welcome to email me after if you want to have something later.
There's a lot there. It's really cool to see the progression too over time, that kind of learning, and just also the ability. I appreciate how kind of you've been able to, your teams have been able to really have those, conversations with the community practitioners and child welfare, but also the legislators. And I think we could do much better with that. And I think this ability to synthesize the data, collect the data, but then push it out in ways that people can really digest it. I think that's really not, that you prioritize that. And I wonder if, we did that much better, we could, really move forward in our state in some of these areas. And so I just really appreciate you talking about also this parsimony and, what's sufficient, and always going back to the what are we aiming for? It's the outcomes. It's actually youth and their families, recovering, doing better, thriving in their lives. And so because a lot of times what we're tracking, or what agencies track, is the dollars and the money and not the actual outcomes. And so, and also kind of moving away, Jason, of what you're saying in our future directions of thinking more flexibly about delivery, kind of looking at that data that's really surprising. People might say, what do you mean fidelity is not associated with better outcomes? And actually leaning into that versus away from it, and looking at scalability and so what's sufficient, what's sustainable. And so thank you, I really appreciate that. But those were just some of my comments and appreciation.
Thank you. Yeah, I think you summarized really, really well. And I'd love to hear any other comments about or thoughts about your experiences in Colorado, anything that rings true, doesn't ring true, because I do know that the context and the state systems are going to have big impact on what you can do and how you can do it.
It looks like
I
Hannah.
do see a hand. Yeah.
Hannah.
Hi, can you hear me?
Mm-hmm.
Great.
Yeah.
Hi, I'm Hannah Brenker Smith. This talk was really great because my research is in a completely different realm. I work on wildfire risk to communities, but where the overlap is that I work with local organizations to collect local data so that they can improve their outreach, their programs, the services they provide to help move households to adopting risk mitigation and disaster preparedness measures. And so there were so many parallels in this in terms of the burden on our partner organizations, the time and effort, standardizing practices across different organizations who may have different organizational goals. And so I just think that this piece with the evidence-based practice piece is so important to so many different disciplines. We have foresters out cutting trees that are not using evidence-based practices on how the forest would grow, and programs doing outreach to communities based on anecdotes and assumptions about what will work rather than evidence. And so I just wanted to express my appreciation for your work and the framing of it. And I guess I do have one question, which is one of the pushbacks we get when we do a lot of kind of technical publications, there's infographics, the really accessible things for our practitioner partners and the public they serve. But we get a lot of pushback when we go to the peer review literature because we get pushback that we're not theory driven enough, that the research isn't researchy enough to stand up to other work in the field that does not involve partnerships, that doesn't have to compromise some measures to meet our practitioner organization's needs. And I was just wondering if you've run into this dilemma as well, and if you have any thoughts on that.
Yeah, thank you. Thank you for your comments and about the talk. But definitely, so, not being an academic institution, we don't really have to publish in the peer-reviewed literature, but, I'm a reformed researcher, so I still like to do it. But yes, I get a lot of comments, not so much about the theory, but about the data were not collected as part of a study, or they're not randomized clinical trial. And all of the concerns that people rightfully have about community-based data that's messy and missing and sloppy, and we get a lot of that. That being said, I mean, usually we can find a home for most things, but it does take a little bit more work than it would if it was collected as part of a a rigorous research study.
Thank you.
I was just going to add too, sometimes it's helpful to highlight, and I think some of the research we were highlighting in other presentations that Jason and I have done together are some of the transdiagnostic models of risk and resilience, and really trying to ground, tie in the theory, always kind of, yes, we need to have an ability to tie that in. And so I just feel like that, and you mentioned the transdiagnostic models, and those are helpful.
Yeah.
And those really, and just for others that aren't, are there like transdiagnostic models, these approaches that seek to identify like kind of core psychological or neurobiological processes, at least in our field, that underlie the multiple forms of psychopathology or risk and resilience. That's what I mean by that. And so if you can kind of look at those cores and then target those, and these different types of interventions and evidence-based practices and evidence-based interventions that actually are core components targeting those mechanisms. And that's why we think that they're associated more reliably with change, right, and positive outcomes. And so similar to, and Hannah, I thought that was so interesting what you just brought up about fire mitigation, because the efforts here that were just done over the last 2 years, everyone's talking about how, those really have made a difference in this fire that now they're still trying to contain right now, in our community or back wars.
Right. I guess there are more ties between our research, right? When the fires burn big, there's much more childhood trauma. So there's all sorts of connections here.
I don't know. Oh.
Go ahead, Monica.
I was just, Fernando, I was kind of curious if folks, if anyone that works on blueprints had any questions. I know some of the interventions are on blueprints, but many were not. And I just didn't know if any of those folks, if they attended or are still here, had any kind of comments as well. Just learning together. Maybe not. Maybe later. Well, I know some folks can't be here, and that's why I'm really excited that this is recorded, Jason, so that we can share it with our larger teams and our programs and all the programs at IBS.
Sure. Yeah, if anybody has any questions later on, happy to talk or email.
Jason, I just had a quick question that it's too basic, I think, but or maybe too general, but those are sometimes harder to answer, I guess. But sorry for my ignorance, but when you mentioned that some of these treatments were seem to be less effective for children of color, if I understood correctly, right?
Well, I think what you're referring to is the outpatient mental health in general as a whole.
Oh, okay.
There are disparities for children of color that are seen in most research. But the evidence-based treatments, at least the ones that we looked at specifically, reduce those disparities.
Okay. Reduce the disparities in terms of the effectiveness of the treatment, or in terms of the prevalence of the issue?
In terms of the effectiveness of the treatment. So, on average, kids who get outpatient mental health white kids do the best, and and Latinx and Black kids do more poorly in terms of their clinical outcomes. But when we looked at the evidence-based treatments, it didn't totally close the gap, but it narrowed the outcome difference between those groups.
Why do you think that's the case?
I was afraid you'd ask that. A lot of people ask me that, and I don't know. But the one thing that I would hypothesize is, I think the evidence-based treatments are fairly structured, and so everybody gets kind of the same set of treatment components. Whereas in usual care, there's such a variety of what people get that it might be that clinicians have some implicit or explicit bias where they're delivering or not delivering certain things to certain children and families. And with EBTs, it's harder to avoid that people don't, that people get the same thing.
Okay.
But I don't know.
Interesting. Yeah, because I was going to ask, is it something related to the types of resources that, the parents, for example, of white children can access that other children wouldn't? But that makes sense. The structure part makes a lot of sense. That's exciting. Thank you.
I was just going to note, and this is for another time, but Fernando, your question, just this morning, Jason and I were in another setting presenting some research, and that there have been some really large meta-analyses done to examine kind of whether anti-Black cultural racism and sexism moderates the efficacy of psychotherapy interventions among youth, and that they were finding, indeed, unfortunately, that yes, psychotherapies tested with samples of majority Black youth were significantly less effective in states with higher versus lower levels of anti-Black cultural racism. So they're doing more of that kind of analysis. And there's a lot more to say about that methodology and things like that, but that it's very much of a how to, even with more, if you're getting some of the evidence-based components, what would, the question of what would make that more efficacious for youth of color. And your, systemic racism is still happening around them. You can teach them coping skills. We have to build resilience, but if you're not addressing the larger systemic issues as well, and that's ongoing, I think that has a big impact.
Right.
Yeah, definitely agree.
Well, but it is encouraging that at least, these particular type of therapies have a way to reducing some of the problems of, that you just mentioned, right? That these kids have, or these young adults have to deal with additional forms of insults and injuries and trauma, I guess, that make maybe the other therapies it's more challenging for the treatments to be effective, I suppose. Again, I'm talking out of knowing nothing about this particular topic, but more thinking about the types of things I know about in terms of health disparities. So anyway, that's encouraging, at least.
Yes. Yeah.
All right.
Thank you.
Well, thank you again, Jason, for a really interesting talk. Learned a lot. Again, in my case, wasn't that hard, but it's really interesting.
Thank you.
Thank you,
for inviting me.
Jason.
You're welcome.
Thank you. Thanks, everybody.
Thanks, Fernando.